Hello everyone, Anthony here with Succeeding in Nursing School, and today will be our first video discussing lab values, and we'll be talking about CBC or complete blood count. In this video, I'm going to talk about the relevant labs within this panel, discussing why some labs aren't so relevant, indications for each lab value, and then the normal ranges of these lab values as well. To start, let's discuss the important labs that make up a CBC. This includes WBC count, RBC count, hemoglobin, hematocrit, mean corpuscular volume, and platelets. Of these, RBC count is the least beneficial as it does not provide a very concise indication of what is wrong outside of whether the body is producing too little or too many RBCs. CBCs usually will also come with a differential, which tracks individual white blood cell constituents on top of a normal CBC. For all of these conditions, cancers of the bones or bone marrow can all cause deficiencies, so I will not be mentioning them along with causes under each specific lab. For white blood cells of WBC, the normal range may vary among hospitals, but is generally around 3,500 to 10,000 cells per microliter. The WBC count is our main tool for tracking progression or onset of an infection and has a variety of different meanings. An elevated WBC count is indicative of an acute infection and can range from slight deviations above to upwards of 65,000 cells per microliter, which is personally the highest I've ever seen in a clinical setting. So when we are treating a patient with an acute infection, we are looking for a decrease in WBC towards the baseline to indicate that resolution is occurring. Low WBC count could be indicative of either an infection that has persisted and is wiping out the host immune system, or that the patient is experiencing immunosuppression from medications or a condition. Sepsis is the most common infection that will wipe its WBC count down below baseline, especially if it's severe. Pneumonia is another common one that can also cause this. The most common immunosuppressing agents we use are chemotherapy drugs and glucocorticoids. So patients with these drugs will typically be on neutropenic precautions, mainly for chemotherapy agents, not really you're ever going to see that for glucocorticoids alone. Other drugs that may cause immunosuppression include certain antipsychotics like clozapine and certain anti-inflammatory agents. If the patient has a low WBC count, you're going to check their bands level, which is an indicator for production of immature WBCs. Typically, this number is below 3% and won't even show up on the lab chart unless it's significant. So anything above a 3% level is going to be showing up on a lab. Bands are the best indicator that an infection is in place, wiping out the host defense, and the body is attempting to compensate. Another lab found on the differential you will monitor during chemotherapy is the ANC. Neutrophils make up the bulk of WBC types. About 60 to 70% of total WBCs are neutrophils. And the first line options for infection are neutrophils. So tracking the ANC is used to determine progression or development of neutropenia during treatment. Most guidelines agree that anything below 1,000 cells per microliter, the drug should be withheld, if not discontinued. Throughout the course of treatment, the physician will be looking at the nadir, which is the absolute lowest neutrophil count during treatment. And with this nadir number, they're going to track whether they need to change agents for the next course of treatment, if treatment needs to be stopped for a little bit to allow the body to recover, or what they're going to do come the next course of treatment. With any type of low WBC, the main worry you have is that they're going to develop an infection. So tracking these numbers is, as well as temperature, is very crucial. Mean corpuscular volume isn't very useful in the hospital clinical setting, but if you're doing nursing home or primary care offices, you'll see this number a lot more. It reflects the volume or size of red blood cells and can be indicative of B vitamin deficiency such as B12, B6, or folic acid. Platelet count reflects the number of platelets circulating in the body, and the normal range is anywhere from 150,000 to 400,000 per microliter, but that may vary again based on facility. A low platelet count or thrombocytopenia could be indicative of a few different things. It could be a result of heparin-induced thrombocytopenia, which needs to be monitored during any kind of treatment with heparin. Low platelet counts could also be the result of medications, primarily other chemotherapeutic agents. But with heparin, if a patient does end up developing heparin-induced thrombocytopenia, they can no longer ever take heparin again. They have to be on other anticoagulants. Certain conditions such as ITP or TTP, hepatitis, and other autoimmune disorders can also cause low platelet levels, as well as sepsis, which is another one due to microthrombi that form. I will discuss sepsis more in depth in a different video, as there's quite a bit to discuss with it and can't fit it all in this one small section, even though we've mentioned it a couple times. With low platelet levels, the biggest concern is bleeding, and the risk becomes higher the lower the levels become. So at around 15,000 to 25,000, there's a chance for spontaneous hemorrhage in the brain. Anything around 35,000, spontaneous hemorrhage anywhere else in the body can occur. And anything under about 75,000, even 100,000, depending on the physician, you're no longer allowed to do invasive procedures due to the risk of uncontrollable bleeding. Finally, with the CBC, there's the hemoglobin and hematocrit. These are the most reliable indicators we have for identifying an active bleed. In males, the normal hemoglobin level is 13.5 to 17.5, while in females it's 12 to 15.5 grams per deciliter. Normal hematocrit in males is 38 to 50%, and in females it's 35 to 45%. Hemoglobin shows us the amount of hemoglobin present in the body. More importantly, it shows us the body's oxygen carrying capabilities. Someone who has an O2 sat of 100% but a hemoglobin of 5.2 does not have as much circulating oxygen as someone who may be satting, say, 85% with a hemoglobin of 10. For this reason, taking hemoglobin into account is important, especially for patients who have COPD, although typically with COPD patients, they're going to have compensatory polycythemia vera, which is going to be an increased hemoglobin at the end. Hematocrit shows us the percentage of intravascular fluid that is comprised of red blood cells. So the 38 to 50% normal range, that means half of what is in the circulating volume is red blood cells. Because of this, it's a fairly reliable indicator for identifying a new or chronic bleed and anemias. I say fairly reliable indicator as both hematocrit and hemoglobin take roughly 24 to 48 hours to change depending on the severity and location of a bleed. So if you have a GI bleed, but you're taking a blood sample from the right brachial artery, the blood levels in that area are not going to reflect what is happening with the bleed. So, for both of these conditions, active bleeds, iron and B vitamin deficiencies, chemotherapeutic agents can all either be a sign of deficiency or cause them. Also, patients who have CKD or in the middle of an AKI or acute kidney injury may develop anemia as the kidneys are no longer able to secrete erythropoietin. For patients with CKD, this becomes a chronic issue and they may need supplemental EPO in order to have adequate red blood cell levels. However, for cases of AKI, you can still resolve the issue before any kind of long-term damage comes down to the kidneys, but eventually, if the AKI goes on long enough, it will turn into CKD and the same scenario will be present. So that is all for this video. As always, like and subscribe if you like the video. Let me know in the comments of any kind of topics you would like to know. Thank you.